Okay, hello everyone. My name's Jill Farrington. I'm with the National Association of State Head Injury Administrators. I am really excited to be here because we're here for our second year. And the reason that that is so important is because of the significant crossover of brain injury among so many populations. We've been talking about many of them today. I think that Dr. Emily Brink really set me up nicely when she started this morning, when she said, we don't want to leave people behind. And she also said, we want to always view employment as a right and not a privilege. So the message that we're bringing today is around brain injury and how often it shows up across populations. Some of those that I think you're going to hear me talk a little bit about is that if we're working in mental health clinics, in substance use clinics, if we are taking referrals from jails or prisons, just like Chelsea talked about this afternoon, if we're getting referrals from domestic violence shelters or from homeless shelters, we're seeing people with brain injury, and that ranges in really astounding ways. And we're going to be talking about some of those when we talk later this morning about prevalence. I'm here with my friend Patricia Henke. We had some technical difficulties in the room that thankfully to the experts in the back of the room, we've come up with a backup plan. And I really do want you to hear from Patricia Henke from San Diego State University, because she has some really important things to say about supported employment and people with brain injury. So please bear with us while we bring her to you through these technical strategies. I will go ahead and move on to the next slide and just say that Patricia and I come from vocational rehabilitation. And I look at it as once a VR counselor, always a VR counselor. I worked with some of you in the room when I was a starting VR counselor, Peter Pike. And we go way back, and we've all kind of grown in different pathways since then. But I was a VR staff person for about 21 years. I was a counselor and I worked with people with brain injury. When I look back, I'm not sure I always did that as effectively as I could have. I supported counselors as they delivered services as a supervisor. Again, I'm certain that we were talking about in problem cases, in appeals, that we were talking about people probably with brain injury that was unidentified. I have worked in academia a little bit in field placement. So educators, I know that you are working to get people experiences as they go through school, because I think I set probably 400 of those up during my time at Thomas University. And most recently, I've been with the Colorado Brain Injury Program, now called MindSource Brain Injury Network. And then for the last 5 years with NASHA, the National Association of State Head Injury Administrators. I am going to ask Patricia to tell you a little bit about herself. Go, Patricia.
All right. Hi, everybody. And hi, Peter Pike. I heard you're in the room, so Jill's going to wave to you for me. I'm Patricia Hankey. I'm the project director with San Diego State University's Interwork Institute, and I'm representing the VRTAC QM today, which is the Vocational Rehabilitation Technical Assistance Center for Quality Management. I'm thrilled to be with you and with Jill, my friend and colleague for many years. Even if it's through audio, we were hoping to get all the technology working, but this is what we have and we will be adaptable. So just a little bit about myself. I've worked in the disability and employment services field for 30 years across nonprofit organizations, vocational rehabilitation, and higher education within the most recently in the last 6 years. And my work has been focused on improving outcomes for individuals with significant disabilities, including those with brain injuries. I joined SDSU 2 years ago after directing Colorado's Office of Employment First. And as Jill mentioned, I am also a certified rehabilitation counselor and began working with the brain injury community actually 25 years ago as a VR counselor. And I'll be talking a little bit more about that later in the presentation. But again, I'm honored to be with you all and to partner with NASHA today.
Okay, and Patricia, if you want to go ahead and talk a little bit about the VR TAC QM.
Absolutely. So hopefully you've heard of the VR Tech QM. We are in our fifth and final year of this project. And we've been partnering with state vocational rehabilitation agencies to enhance service delivery and maximize outcomes through technical assistance and training, primarily in fiscal and resource management and program and performance management. I'm proud to say that as of December 31st, 2024, VRTAC QM has provided TA technical assistance to 78 state VR agencies, which is 100% engagement. So we know these topics are of high priority for VR agencies across the country. Also wanted to share that SDSU, under the VRTAC QM, has continued to facilitate the National Vocational Rehabilitation Community of Practice on customized employment. This actually began about 7 years ago prior to VRTAC QM through WINTAC, which was the Workforce Innovation National Technical Assistance Center. And this COP, I'm mentioning this COP commuter of practice because we will be continuing this initiative beyond the VRTAC QM grant. I know there's lots of conversations about, the project timeline ending and things not continuing. But because SDSU is involved in several Disability Innovation Fund grants through RSA with an emphasis on customized employment, we are able to continue the COP, and it's a very active, engaged, robust group. We also have projects through the Department of Labor that will also allow us to continue this work forward. So feel free, and we encourage you to visit our website. Lots of resources, lots of community of practices that are still occurring.
Thanks, Patricia. And just quickly about the National Association of State Head Injury Administrators, where I come from, we're a nonprofit membership organization, and we're essentially working with state governments and their partners to try to improve the lives of people with brain injury. That's kind of it, high level. We do that through a variety of different strategies. We provide resources and information. One of the resources that you'll be hearing about today comes from a partnership we have with the Disability Employment Technical Assistance Center. So I'm excited to share with you a resource that really mirrors this presentation in a lot of ways. And it was just released last week. We do training and professional development regularly. So if you're not on our newsletter list, you might consider doing so. And I've got a QR code for you at the end. We work on establishing connections between systems and state lead agencies on brain injury associations. We really work to bring everyone together to talk about the brain injury factors that help people succeed and also the factors that sometimes set them back. We are oftentimes putting out information about state and national trends, and we're doing advocacy, especially right now, trying to preserve some of the research arms of brain injury. And we're looking, for example, at the community engagement requirements that are likely coming our way or work requirements. We personally feel like there's a lot to talk about in that area. People with brain injury may not be exempted from work experiences, and we want to hold up that they should certainly look at work. We also want them to be successful as they demonstrate that they're working and hold on to that Medicaid that they may very well rely on. So we're doing a lot of advocacy in that space right now. If anybody else is curious or has an interest in talking about work expectations, community engagement requirements as part of Medicaid going forward, would love to have a conversation. So here's what we hope that you walk away with today. We very much want to start out with a bit about just brain injury factors in general and things to consider as it relates to participating in an employment program. The ways that employment can be quite complicated for people with brain injury, especially when it's not known. We'll move into understanding that people with brain injury are oftentimes really good candidates for supported employment, customized employment, self-employment, supported self-employment. I could keep going. And because I worked in Colorado's VR program, I know that Colorado has a really big commitment to helping people get the kinds of supports that they need, but sometimes along the way, things can fall apart, and that's partly what we're going to talk about. We want to focus towards the end of the presentation on what are the options if somebody doesn't have long-term supports, paid long-term supports typically through Medicaid. So we'll dive into that area as well. If you don't feel like these learning objectives have been met, I hope you challenge me at the end with your questions, and we'll bring about more clarity, or I'll go away and find out the answers to your questions. So we wanted to find out who's in the room today, both here in the ballroom, but also online. So this slide has a QR code for you in your offices or at home or here in the ballroom to click on and just tell us your background, what you would pick as your first choice of the role that brings you here to this conference. And here on my screen, I will be watching to see those results start to pop in. We'll give it just a couple minutes. Now, if things were working perfectly, you would see the results also, but I'm going to tell them to you, and they're still populating. So in a moment, I'm going to share with you how our audience spreads out across these categories. And again, they're continuing to populate. All right. I think we're slowing down a bit. And I wanted to tell you all that we have about 120-ish responses from those of you in the room, which is about 20-ish based on my count. And so about 100 online that have participated, still growing a little bit. But by and large, VR counselors and community-based employment service providers are with us today. That makes me so excited for you all to hear this presentation, and more importantly, to give some of your input, give some of your strategies, what's worked well for you, and there's going to be opportunity to do that at the end. We also have about 25% VR or community-based supervisors or administrators. So again, really glad you're here, because as you provide clinical consultation to your staff, the messages that come through today, I think, can be nice takeaways. We've got a good sprinkling of educators and students, and then we have, again, about a quarter of people that categorize themselves in that other category. So thank you for participating in our poll. Let's go ahead then and dive in and get started by getting on the same page. And the way that we're going to do that is really just to talk about how we and a lot of our partners talk about brain injury currently. It's changed over the years. We really look at brain injury under a large umbrella term of acquired brain injury. So sometimes you hear ABI, and that to us means that somebody's either had a traumatic brain injury, meaning that they had their injury by external force, or that they had a non-traumatic brain injury that may be due to a stroke or anoxia or a cardiac event. There's a lot of different ways that people are experiencing both non-traumatic and what we typically think about, which are traumatic brain injuries for people that have had blows to the head, might have been in car accidents, might have had experience in a blast explosion. But the key thing is they're all experiencing very similar brain injury symptoms. So we don't feel like it's needed to try to differentiate traumatic and non-traumatic when it comes to community-based supports for people living with brain injury. So wanted to first clarify that. And then just talk a little bit about how it seems to us that brain injury can show up in the cycle of symptoms and how client engagement works out in employment programs, not just vocational rehabilitation, employment networks, people that are participating in a TANF employment program. So on the outside boxes of this slide are some of the symptom areas. The first one on the upper left is an executive functioning issue of organizational skills. If I remember being a VR counselor, I know that that might be looking like the person who agreed to drop off a set of paperwork absolutely said they were going to do so on their way out the door, and it never shows up. That just fell off. So that executive functioning skill can absolutely complicate someone's service delivery. Another executive functioning loss is at the bottom left, and that is executive function areas of memory or lack of follow-through strategies. So imagine the person that you've worked with, you've had them do a mock interview, you've helped to find what you believe might be the really perfect job for them, and then you find out after you've got them job placement clothing and they felt confident about their job interview that they missed it completely. Huge blow to that employer potential employee relationship as well as the person's self-confidence. The upper right-hand corner moves us from executive functioning more over to physical and sensory issues. And so here, somebody might, in ways that are completely hidden, have stark issues with light or noise sensitivity due to their brain injury. So that might be the person who we see completely fidgety, seemingly uncomfortable, edgy, in the intake or in a subsequent meeting to help with employment planning. And it can then sometimes be perceived like, does this person really want to work? You know, what's going on here? And really what may be happening in the background, if we don't know it already, is brain injury. And then the lower right-hand side brings in the symptom area of emotional regulation or judgment issues. And this may be that person that got the good job and it seems like everything is falling into place, but the supervisor calls and says, I'm not sure if we're going to be able to keep, Johnny, that we're getting all these inappropriate remarks. So again, if we don't know that the brain injury is there, it's certainly going to be complicated for that person. There's some areas that we really try to keep our radar up about in particular beyond what we just covered. And those are some of the complicating factors that are sometimes associated with brain injury. Big one is on the upper left hand part of the screen, co-occurring conditions. Brain injury shows up with behavioral health so often. Mental health and substance use disorder clinics are seeing people, whether they know it or not, with brain injury. Probably, at least 1 out of every 2 people in their waiting room are those that have had brain injury based on significant research, both program evaluation and university research all over the country. So as the community-based clinics for behavioral health are starting to kick up, we're having a lot of conversations about recognizing brain injury and supporting it. And there's great tools for it. The other thing that we take a look at and keep our radar up about are complex, mild, and repeated brain injuries. So sometimes a person may have had what they call a concussion, which really means that they had a mild brain injury, and they may or may not fully recover from that brain injury. About 75% of the time people do. But if they end up having another brain injury in real close proximity, that likelihood of a stronger recovery begins to go down. And we think about that with intimate partner violence, with sports, that somebody may sustain a brain injury very quickly again, and then this cascading effect of problems can start to be seen. And then certainly thinking and paying attention to trauma as it relates to brain injury, knowing that people are, when they come into our doors in voc rehab, for example, are grieving their old life as they start to think about a new life. And that could be very complicated for individuals, especially for a period of time where they feel quite hopeless. We want to, on this, next slide, give you that statistic of behavioral health and brain injury. That prevalence rate, based on studies, is about 60% when we look at mental health and substance use disorders. And when we think about Chelsea's presentation earlier today about people coming out of correctional settings, this is, it all starts to weave together and connect. And we have to have that on the top of our minds. So it all kind of boils down to this, that, and we're talking right now about hidden brain injury, and we'll move more towards supported employment. But what we think about for successful VR participation is that we are working with somebody with or without supports that is showing some level of reliability and that can engage and doesn't get shut out of the process, due to some symptomology or some behaviors that are not understood. But on the right side of this graphic is that the brain injury barriers, when the symptoms are unaddressed, can lead to significant problems. And you all know this: initiation, following through, emotional regulation. That's just kind of the slide to summarize what we've been talking about. Now I'd like to share just a little bit about some of the other numbers. We talked already about behavioral health. You'll see on this slide a real increase as you work from left to right. We know that school age youth, while the general population, according to the Centers for Disease Control and Prevention, know that about 5 to 8%, somewhere in that vicinity of the general population, have experienced brain injury. We know that when we're looking at school age youth, that that's more around 10%. So it starts to creep up. However, really big qualifier here, much higher if the child or youth is in the child welfare system, is in foster care, then those rates are going to be quite a bit higher. So we just know that when we're doing an intake with somebody that has that life experience. When we move over to the next box, older adults, that rate starts to go up in the research to about 13%. And we heard today that the VR population 50 and above is what I think about a third of the people that are wanting services. So this area of knowing that people that are older adults are sometimes wanting to work longer, needing the right kinds of supports, makes us think about the fact that brain injury may be a factor, especially for people who've had polytrauma. And, now we're kind of moving out of the work age a little bit, but if my grandmother falls and breaks her hip, but she also hit her head, if I don't take into account that she might have had a concussion, which equals a mild brain injury, I may really misconstrue some of the behaviors that I see after that. But here's where we really get into the bigger numbers. And this first one of youth and adults in the criminal legal system, this number is about 50%, but that's very much an average. Youth and adults that are earlier in the criminal legal system. So maybe they're in diversion or they've kind of maxed out at probation. Those tend to have lower rates of brain injury in the research. But when we start looking at people that are being deinstitutionalized from youth corrections and from adult corrections, those numbers really climb into the 60, 70, 80% level. That may be due to brain injury that resulted in them becoming in trouble, getting in trouble. And it also sadly is sometimes a result of being in those institutional settings where, violence can happen and brain injuries can occur or reoccur in those settings. Homeless population prevalence, we're seeing around 50 to 60%. A lot of times where this is coming from are point-in-time studies. If some of you heard of the point-in-time studies that annually look at the homeless population, when screens are done with those populations, we're seeing about a 60% prevalence rate. And then finally, the most startling one is in the area of intimate partner violence. That is upwards of 80, 90% of not just women, men, but many women who've experienced brain injury and maybe struggling to engage in their services due to brain injury that could result from blows to the head, from choking, strangulation. These are really, really high prevalence rates, and we want to continue to put this information out there. What we can offer up in this area and is happening in many different states and a growing number of states is this area of screening. Now, when I was a VR counselor, many people came in and they had brain injury. They have medical records. They might have been in a rehab hospital. They'll tell you, I was in a coma for this amount of time. And we know that we're working with people with brain injury there. However, we know that the numbers of people that actually experience brain injury is quite a bit bit higher. So there's tools that exist to be able to identify those. They're evidence-based tools that in some cases are self-report, and they help to reach people that were maybe never seen in the hospital. And you can see this fact on the left side of the screen that 42% of people who've indicated they had incurred a TBI as defined by the Centers for Disease Control and Prevention never even sought medical attention. So why would that be? Maybe they got a brain injury during criminal activity of some sort. Maybe it was during an intimate partner violence situation. Maybe a person wasn't legally present in their state and didn't seek treatment or hospitalization, ER services for that reason. There's a myriad of reasons why that is a case. But as the middle paragraph indicates, when we know that a person has a brain injury, then we can fold that into our holistic approach for delivering services. We also, in final kind of statement on this slide, know that if we realize brain injury exists, then we're much more aware of the potential for challenging behaviors and the risks that those present. Well, there is one tool I'll highlight briefly, and that is the online brain injury screening and support system, otherwise known as OBIS, and it's starting to creep up in use all around the country. Colorado is a state where it's very utilized right now. Alabama, Missouri is starting to use it with intimate partner violence shelters. And it is a validated and reliable tool that is self-administered. The reason why that's so helpful is that sometimes when screening needs to be embedded in an intake process, it takes some time. And we know that staff in employment programs are already extremely busy working through paperwork requirements. This can be a tool that can, for many people, be done at home. It can be done in a waiting room or a lobby. It uncovers lifetime exposure to brain injury first, and then if that screen is positive, it moves into looking at symptoms the person self-reports. And then finally, tip sheets are generated for the person based on their symptoms. When I was a counselor, if a person had a brain injury and I just thought, well, I got to do something. They've got a brain injury. They're going to go see a neuropsychologist, and I need to, manage, any and all symptoms. These kinds of tools tailor it down so you can really target the kinds of compensatory strategies that may make a difference for the person. And I would get that as a provider, but more importantly, my participant or client would get the same corresponding tips. So they can begin doing some their own strategies, their own modifications in their day-to-day lives that will hopefully bring about positive change. So now I'm going to shift gears just a little bit and talk about the fact that people with brain injury have employment needs all across the spectrum. And I know I'm speaking to everybody in the room that already knows this. I just want to highlight it before we bridge to the supported employment focus. Some people after brain injury, they have had a long work history. They may come to VR and they simply need some lighter touch services. They may need retraining because what they used to do, they can't do anymore. Or they may need assistive technology. They may need what I call the premier service of voc rehab, which is vocational guidance and counseling. They may need help moving from that prior self to what that new self can look like in hopeful ways. But there are many others that are more on the right side of the spectrum that may need more substantive services to be able to get and keep work. So they may be really good candidates for discovery, job placement with supportive coaching, or sometimes called systematic instruction. And most importantly, they may need extended supports. They may need somebody that can check in on them or help them move through a dilemma for potentially the length of their employment, depending on the severity. So with that, I'm going to talk a little bit about what we see across the country around brain injury waivers. Maybe some of you are in a state that has a brain injury waiver. You'll know it if your state is red or kind of that light yellowish shade. And then you'll see many, many other states that don't have brain injury waivers. That doesn't mean that an individual with a brain injury isn't on some other waiver. Depending on the age they were at the time of their injury, they may be on an intellectual and developmental disability waiver. But we wanted to just highlight for you all where we see brain injury waivers in states and which of those have employment services. And it's maybe a little bit more than half. There are those states in red that have decided it's important enough for our waiver to support people to go to work that we're going to put supported employment services as in our service array. And we want to see all the states have, those supports, or if needed, we want to help people link up to the right kind of waivers that will help them in their employment endeavors. So we wanted to bring this up again, showing you all the states in red where we're seeing really good pathways to employment for people with brain injury when they are eligible for a brain injury waiver. Here are some of the examples of those services and how they're described in brain injury waiver documentation that the feds get and approve. So on the left are some of those traditional services that you would expect to see. So if supported employment is in a brain injury waiver, it's then meaning that the person likely has some access to placement, coaching, discovery, person-centered employment planning, et cetera. And then that big important bullet, that likely also means that they could have some intensive ongoing supports. That's very exciting. On the right-hand side, we're seeing maybe what could potentially over time be viewed as promising practices, innovative ways that states are maximizing their waivers for employment. So customized employment is specifically called out in the states that have been listed here: Connecticut, Iowa, Maryland, Nebraska, South Carolina, and Utah. Very exciting to me personally is that many states hold up self-employment as a specific support on a brain injury waiver. So those states are listed there. I won't read them out loud. A variety of other types of supports, financial literacy, development of experiential learning opportunities. The point being that some Medicaid and waiver staff are really, listening to, I think, the employment first push, which is we need to set ourselves up for people to succeed in their employment pathway. Sometimes it means they need these more intensive services. So at this point, I'm going to invite Patricia to come back on and talk a little bit about her experience working extensively with people with brain injury in her career. So Patricia, you are back on the mic.
Oh, thank you so much, Jill. I was able to hear your presentation. That was fantastic. So I'm going to talk a little bit about a counselor experience. So Jill shared such great information about acquired brain injury, traumatic brain injury, and just kind of the VR, what the VR experience could be like. And this is actually a real life experience that I had with a VR client. And actually, her name was Sophia. And I think we probably all have had teachable moments in our career from individuals with disabilities that we've worked with in some capacity. And I really try to make it a priority to always think with a job seeker or individual with a disability in mind when I'm working on policy development or improvements and training. And so I often will reflect on this one as it relates to brain injury in my work. So the scenario is, not the scenario, it's actually a real life experience where I was new to VR, a newly hired VR counselor. And at the time, I had my master's in rehabilitation counseling, I had my CRC credential, and I actually had 10 years of experience, prior experience, managing support employment teams serving individuals with intellectual and developmental disabilities in competitive integrated employment. And and that was one of the reasons I was hired, because I had prior experience and could come in and do the job quickly and had a lot of background and connections and resources that I had acquired. And within 2 weeks of being hired, I had a caseload of 75 individuals with various disabilities, what we call a general caseload within VR. And so I started meeting with clients, and this was actually a new intake, so one that was being added to my 75 individuals that I was working with. And Sophia was the VR client coming in for an intake, and she was seeking VR services. She hadn't been to vocational rehabilitation before. She did self-report that she had experienced three mild traumatic brain injuries. She was in her early 40s. She had a bachelor's degree, previous intermittent work history in leadership positions. And financially, she was dependent on her current partner or partner at the time, and she was not receiving any public assistance, SSI, SSDI, or Medicaid. And she was a very enthusiastic person, and we had an amazing meeting. And let's go to the next slide, and I'll talk a little bit about the intake highlights. So Sophia was very enthusiastic and excited about getting her vocational rehabilitation services started. Rapport was easily established, and she shared more information about her traumatic brain injuries. And when I asked about, any type of limitations or residual difficulties, she communicated that there wasn't anything significant, that there wasn't anything that she was really concerned about in terms of going back to work. The meeting lasted 60 minutes, and it was really productive, talking about her previous work experience and career goals. I think it's important to note that the meeting was held in the VR office, so it wasn't a community-based meeting. And my office at the time had a large window facing the mountains in Colorado, and it was very sunny that day. And at the end of the meeting, we had a plan to meet again, and our next steps were to follow up and begin the comprehensive assessment process and developing her individual plan for employment. And let's go to the next slide. So what happened next is Sophia was a no call, no show for her next meeting. And we're going to talk about why and why this was such a teachable moment for me as a young VR counselor. Once I finally did get in touch with her, it had been a few weeks, and we had, left voicemail messages for each other. And once we finally talked, I learned that she didn't show up to the meeting because she had such cognitive fatigue from our intake meeting that she was essentially in bed for a week. That she had so much cognitive fatigue and cognitive shutdown from the energy that she put forth in that meeting, that she just she couldn't communicate with me, she couldn't show up. And another lesson learned just in talking with her is that the sunlight coming through the window was too bright. And she didn't realize that at the time to say anything, and I certainly didn't ask about it because I didn't realize that was going to be an issue. In hindsight, the meeting was too long, that was too long for her to be engaged cognitively with me at the time in conversation with such enthusiasm. And one of the things I learned is that she didn't have the awareness at the time of how to manage her cognitive energy, and wasn't aware of what might be limitations or things that she would have to consider. She was so enthusiastic about going to work and relaunching kind of her career and career goals that I think just getting kind of wrapped up in that energy and not thinking through things that we really needed to consider in going to work and making a good match for her long term. And for me as the counselor, although I had 10 years of experience, I didn't have prior knowledge of working with individuals with brain injuries and actually not a lot of experience working with individuals with invisible disabilities. And so, huge lesson for me in terms of my own knowledge base and areas where I needed to learn and grow to serve this population effectively. And it was after this experience that I started researching resources on my own fruition. And I thought it was worthwhile sharing this experience for those that are in training roles, that are in supervisor management roles. And I know that brain injury awareness has increased so much since this experience, and I'm so grateful for that. But there are situations where I think counselors may not have the information and knowledge to work most effectively with individuals that are coming in. And we may not know. We may not know an individual has a brain injury. And that's why when Jill talks about screening tools and questions to be asking at intake, why that is so important. So after this experience, and I started doing research, this is when I found the state brain injury program. At the time, there were circle groups that were available. We didn't have one in my area, so ended up trying to create one. And I started reading. I read a book called Brain Lash by Gail Denton, that was incredibly valuable and actually gave me more knowledge than I ever had attending a training. And Gail is an individual with a brain injury, and she really speaks to her life experience and in all areas of her life, as well as vocationally when it came to having acquired brain injuries. And this is one teachable moment of many, but I was able to course correct immediately in working with Sophia and then other individuals with brain injuries. I had what I learned later is I actually 25% of the individuals that were on my caseload had brain injuries um, in, for various reasons, sporting events, car accidents, falls, but realized that, and a lot of co-occurring disabilities as well. But really that fueled my kind of passion for learning more and actually becoming an advocate for really asking the questions to help people know whether they have limitations or residual difficulties as a result of a brain injury versus another disability.
All
And
right.
so,
Move to the next
yeah,
slide. Okay,
absolutely. Yes.
quick time check. We're right at 15 minutes.
Okay, great. So this slide, and Jill spoke a little bit to support employment and customized employment pathways as options for individuals previously. And this just slide shows the criteria that is often used to determine if someone can benefit from support employment services. And all of these or some of these may be true for individuals with brain injuries. And really looking at these and thinking about these kind of beyond the working with individuals with intellectual and developmental disabilities and or mental health or behavioral health disabilities, and thinking about it broader and inclusive of individuals with brain injuries as well. And really thinking about it right from eligibility determination, comprehensive assessment, and then IPE development, just thinking through the lens of inclusivity of individuals with brain injuries in those VR processes. We can go to the next slide, Jill. And thinking about customized employment as an option as well, and a viable option for individuals with brain injuries. CE, customized employment, we know is a universal model and can benefit all disability populations. And that may not be where an individual needs fully customized employment, but could benefit from the discovery process, which we go to the next slide. I think it's on the discovery process. And I'm gleaning that there's many of you that are very knowledgeable about these services in the room. So I'm not going to spend any much time on this, but it's really that qualitative, no-fail, person-centered process that is just so important. You know, Sophia was a no-call, no-show. I I have seen where that experience could be perceived as someone's not motivated. They're not interested in service. They can't engage and would move forward to determine whether that case should be closed or not even move forward. So if we look at it from a no-fail, person-centered process, then we really look at things observationally rather than evaluating through discovery. And this really could be advantageous to individuals with brain injuries as well. And we can move to the next one. Jill talked about sequencing services and the importance of this. And this is just the resource through Department of Labor, Office of Disability Employment Policy, which has extensive resources on how to braid funding and services. Like, it doesn't always have to be funding. We know that not all long-term supports are paid supports. And your VR and Medicaid is who are braiding services often, as well as behavioral health and education and other state agencies. In Colorado, where I've had many years of my work, these resources weren't available when we started to sequence services between VR and Medicaid. And once these were published, it was really validation that, okay, we are on the right path. We are innovating and figuring this out. And in actually having these resources helped make the case to other state agencies or service provider organizations that sequencing services is approved essentially and is something that can be done from a federal perspective. And I think that's where I'm going to end. So there you go. Thanks.
Thank you. Yeah, thank you very much, Patricia. And I
Yeah.
just wanted to mention that I sometimes believe that in states, counselors that work with people who have intellectual and developmental disabilities, they know their Medicaid counterparts. They work really closely with them. They know kind of how to do this. We find a lot of times that when people are getting a brain injury waiver, even in those states where employment is offered, this is just not quite on the radar as much yet. So there's a lot of still opportunity to strengthen in this area of sequencing and braiding and take those great practices from IDD and move them over to what we're doing in the space of brain injury. So we've talked quite a bit about supported employment, customized employment, but we also know that for some people, when we think back about that map, they don't have the access to those paid long-term supports. And so some of you have done the next question in the Mentimeter, and if you haven't, I invite you to do so now. And in one or two words, what alternatives have you found helpful when paid long-term supports or extended services are not available? If you need to, you could rejoin with the QR code. I do see more responses coming in, and we'll give it a few moments to share back with you some of the knowledge that is coming from many people around the country who run into this gap a lot. Yes. Oh, yeah. So there's a question here in the room, Patricia, about the name of the book, Brain Lapse. And would you, while we're waiting for more results to come in, could you repeat the name and the author of that book? Okay, try that again. Patricia, do you want to name the book and the author one more time for Brain Lapse?
Oh, it's Gail, Gail, Denton, Denton.
Perfect.
Brain lash.
Okay, we've had quite a few responses come in, and the expertise that is in this audience of trainees is showing up significantly with some of the ideas being family, natural supports, community, friends, ticket to work, coworkers, community resources, employer supports, and the list really goes on and on of some of the ideas that are generating from the discussion today. This is not new territory for many people. When a person is able to go to work with supported employment but needs extended services, we have to put on our creativity hat and figure it out. So with that, I'm going to give a quick spoiler alert. You might have heard me say earlier that there is a two-page resource that was just put out last week that covers many of the topics I've got on these slides, which are really just a compilation of what are some of the strategies that could be employed. The first one, I'm sure you all are quite familiar with, is if I'm working with a person who has got a brain injury and they need supported employment, don't have the long-term support option, but they're a Social Security Administration beneficiary under supplemental security insurance or Social Security disability income, then I'm going to get them to a benefits planner. And we're going to potentially find an option that helps a person to essentially pay for their own long-term support. But then the money that's used for that support will be a deduction when Social Security determines countable income. Basically, that just means that they're going to recoup all or some of those funds. I give a real big hats off to benefits planners because we know that they do the hard math and they are, crucial with helping us not shut down supported employment when somebody can benefit. Another option is ABLE accounts. I'm sure most of you are familiar with those that allow people to save funds up to $100,000 and that the funds are not considered countable resources for federally funded benefits. Very exciting. What's more exciting is that this program has historically been for people whose injuries occurred before the age of 26. And effective January of 26, that age changes to 46. So we'll open up ABLE for many more people. And the long-term support could potentially be a qualified disability expense for ABLE. So that's why we included it on the list. The other possibility is there may be a better or more appropriate waiver for a person. If we know we're serving somebody on a brain injury waiver where employment supports aren't included, but maybe the person did have their injury under, say, 22, they could potentially shift over to an intellectual and developmental disability waiver. So that might be an area where we get creative. Or in some cases, depending on the age, we might see that individuals have extended supported employment intensive services for a little bit longer. This is especially true for youth who could get supports up to 4 years or until they're age 25. We also know that employment networks could be an answer for people maybe who have a little bit less intensive needs. Centers for Independent Living oftentimes have an arm of employment that we should really understand in our states. It was very much included in our Mentimeter, natural supports and private pay supports. Now we just want to make sure we leave you with a number of resources that have been linked in your presentation, and they were designed for people living with brain injury, VR counselors and employment service providers, centers for independent living, and community service providers. So there's, I think, 6 of them here that are linked for you to be able to use and ideally distribute, disseminate, share to keep that message of employment front and center. This is the article I mentioned to you. It's got a QR code for supported employment, long-term support approaches for people with brain injury, so that we can tell people with brain injury, if you need a lot of support to go to work, go for it. There are creative ways to help you get there, even if the long-term support paid option isn't there. So this is at the DTAC site, but it's also linked here. This website for the DTAC, where NASHA has partnered so much, has lots more podcasts, blogs, webinars, and that QR code will take you directly to the DTAC page. So we want to open it up for comments and questions that you all might have for me. And so by a raised hand, I think there's a microphone to be moved around. Anybody have a question, burning question, or success strategy that you would like to share? Yes, over here on the left.
I noticed that on one of your slides, it talked about the intimate partner violence at 90%. Is it noticeable among various states that may have higher results of substance use or have integrated different types of substances or different things? Without
What
saying
I,
it is.
yeah, what I am taking away from your question is that we start to see these life experiences stack up on top of each other. A person may have been in an intimate partner violence situation. They may have had opioid addiction. They may have had a history of blackouts, overdoses. We're likely working with somebody who's had either a non-traumatic or a traumatic brain injury. And I love that you're kind of elevating that notification of this is a person when all these different factors are what they're presenting that certainly may lead to a brain injury conclusion. Other questions? I wanted to just say a couple things about how we can stay connected, and that is through the National Association of State Head Injury Administrators has a newsletter link that I can get to you. We would love to connect you with your local state brain injury lead. They're oftentimes housed in your state departments of human services, but sometimes they're housed in behavioral health departments or public health, but we can connect you to that at NASHA. And we also have a conference that's coming up at the end of October in Portland, Maine, which is a great place to go. And we will have a criminal legal system track, a behavioral health track, and a long-term services and supports track. So many of the things that you heard me talk about today are going to be even more of a focus, and great speakers are coming together for that conference. So reach out to me. Patricia's email, my email are both here in your slides, and we really thank you for coming today. Thanks.
Jill, I had a question.
Oh, sure.
So in your work with individuals with TBI, have you run into individuals having lack of self-awareness?
Oh, so the question around when brain injury is a factor, lack of self-awareness, is that sometimes seen? And it absolutely is. At the same time, it's not always seen, which is a great illustration of the fact that if you've seen one brain injury, you've seen one brain injury, because they're all very different. And the more that we can define where people are struggling, either from their self-report or observation, then we can tailor strategies that are available, evidence-based strategies to make a difference for that person. So you're absolutely right that lack of self-awareness can really get in the way, and there are evidence-based strategies to work on addressing that. So, all right, time. Please let me know if you have any questions. I'll be around. Thank you.